Okay, so let's start with the specific injuries now. The sections, different upper limb, lower limb, spine, sports, and all those things. So this very first section we are going to talk about the injury of the injuries concerned or related to upper limb. Now in this section we are going to talk about the injuries which involve the joint from the shoulder area, neck area, till the tip of the fingers, all the bones getting fractured. Now around the shoulder, this big, contour of the shoulder is all because of your rotator cuff. Okay, so some basic injuries and then the specific bone injuries. So first we talk about the details of the number one. We talk of details of rotator cuff. We talk of details of rotator cuff. How the rotator cuff is formed? Because there, a rotator cuff for last many years it has not been asked to you. But before that, rotator cuff was a common question almost every alternate year. Okay, rotator cuff of the shoulder is formed by four muscles. That is, you all know that: supraspinatus, the infraspinatus, infraspinatus, teres minor, the teres minor, and subscapularis. Okay, so supraspinatus, infraspinatus, teres minor, and subscapularis. These are four muscles which make the rotator cuff. Okay, out of these, the supraspinatus is the most common to get injured. It is the most common to get injured, right? So out of the four muscles, SITS, how do we recognize them or remember them? The S, I, T and S. The supraspinatus, infraspinatus, teres minor and subscapularis. So most common to get injured is supraspinatus, right? Now what is the function of each one of them? The supraspinatus, basically this has got a function to start the abduction of the shoulder. How much? From 0 degree till 15 degrees. So abduction of 0 degree to 15 degrees is done by the supraspinatus muscle. Infraspinatus, this has got the function, and these two basically, both of them, they have got a common function of external rotation of the shoulder. They have got a common function of external rotation of shoulder. And subscapularis, it is related to internal rotation of the shoulder, right? In relation to this internal rotation of the shoulder, there has been a question which has been asked in PGME, and that is about the lift off test. How to test for the internal rotation which is done by subscapularis? It is by lift off test. What we do in lift off test? What we do is we ask the patient to keep the hand on the lower back like this. Okay, your hand is on the patient's hand now. The examiner stands on the back side of the patient and he keeps his own hand on the patient's hand and ask him to lift it. Ask him to lift it against some little resistance. So lifting it off from the lower back, that is lift off test. So another MCQ here in the rotator cuff, it is about the lift off test, right? So most common to get injured, supraspinatus, and lift off test, it is done for subscapularis, which actually checks for terminal internal rotation of the shoulder, right? Now the grades of injury and how do we manage the rotator cuff injury? Basically it's a bulk over here which maintains the contour of the shoulder. If the rotator cuff is injured, depending on the injury, there will be clinical manifestations, right? How do you manage them? What are the grades of injury? I'll just tell you in very brief. It's not very important for you, but yes, we cannot ignore it because there has been question in your past, there had been question in your past exams from this particular topic, okay? So the grade of rotator cuff injury, the grades and treatment, for rotator cuff injury, the grades and treatment for rotator cuff injury. Treatment, okay? So grade 1 injury, the grade 1, when do you say it is a grade 1 injury? Grade 1 injury is said to occur when the tear is less than 50% of articular surface, right? When partial thickness tear is there and which is tear is less than 50% of the articular surface involved, right? Grade 2 tear is when the tear is more than 50% of the articular surface involved. right? Grade 3 tear, grade 3 is considered a small to medium tear. Grade 3 is small to medium tear, which actually is considered less than 3 centimeter, or we can call it a small tear when there is only one tendon involved. So either it is a less than 3 centimeter tear or it is one tendon involvement in the grade 3. Grade 4, grade 4 is a moderate kind of tear. Grade 4 is a large massive tear. It is a large massive tear which is actually 3 to 5 centimeter, which is around large massive tear which is actually 3 centimeter and repairable, and here involvement can be of 2 to 3 tendons, right? Grade 5 is again large massive tear, but then everything will remain same, but it is not repairable. So grade 5 tear, they are not repairable, right? And grade 6, the last grade of injury that we have in the shoulder, rotator cuff, the grade 6 injury, these are retracted, these are massively retracted tear, retracted massively, and irreparable tear. Irreparable tear with intra-articular involvement. That means they have involved the joint also with intra-articular pathology. Now see how we can remember it. The grades in tear, grades of the tear of basically rotator cuff, less than 50% of articular surface, 1, more than 52. Massive tear, basically some grade 3 will be a small tear, less than 3 centimeter. After small, grade 3, everything is massive. If it is repairable, grade 4. Not repairable, grade 5. Intra-articular involvement, grade 6. Finish. How do you treat them? Well, you can understand for these two, or simply say these 3, what we can do is, we can go for arthroscopic repair. Very simple. We can go for arthroscopic repair and decompression or debridement, whatever is required, arthroscopic repair, plus minus if required acromioplasty. If needed, we can go for acromioplasty. So arthroscopic repair and acromioplasty, right? When it is a large tear here which is repairable, so what you will do is open or arthroscopic. Here you should go for it. Open or arthroscopic repair. If arthroscopic possible, well and good. No, go for open repair. If this is not repairable, here the treatment is tendon transfer. Tendon transfer, and if possible some sort of repair is possible, so go for partial repair. Go for partial repair. Okay. And if it is retracted, intra-articular area is involved, joint area is involved, then we go for reverse shoulder replacement. Reverse total shoulder arthroplasty. Total shoulder arthroplasty. Right, so tendon transfer is done when it is irreparable, when it cannot be repaired, very simple. So when you cannot repair it, tendon transfer. Joint is involved, replacement, that is very simple. So if the joint is involved, go for replacement, right? If it is irreparable, then you can simply go for reverse total shoulder arthroplasty, right? Now we can talk about the injury, another injury around the rotator cuff, or basically you can the shoulder area, and that is what you call the dislocation of shoulder. This is one of the most important topic, although question has not been asked for last few years, but still it remains one of the most important topic. Reason is simple, the shoulder is one of the most commonest joint to dislocate, right? Reason is again very common. Reason is that when you see the shoulder area, the glenoid and the size of the head of humerus, it's almost in a ratio of 1:3. right? The head of humerus is almost 3 times bigger as compared to the size of glenoid. Glenoid is small, head is big. So glenoid cannot keep the head intact in it. The head easily can dislocate, right? The humeral head is very big, 3 times almost as compared to the size of the glenoid. That's why shoulder dislocates so often, so commonly, right? So dislocation of the shoulder, this is one of the most commonest joint. This is one of the most commonest joint to have recurrent dislocations. To have recurrent dislocations. Okay. Now we can talk about the types of shoulder dislocation. But do remember, before we talk about the types of shoulder dislocation, do remember that every dislocation, whether it is shoulder, hip, any area, every dislocation is an emergency, right? Consider every dislocation is an emergency because dislocation can compromise the vascularity of a joint. Dislocations, they can compromise the vascularity of the bone, and if the vascularity is compromised, the bone will land up into finally into avascular necrosis. So consider every dislocation as an emergency, right? When we are talking now specifically about the dislocations of shoulder, let's discuss that in detail. So broadly there are 3 types of dislocation of the shoulder. One is anterior dislocation, other one is posterior dislocation of the shoulder, and third one is inferior dislocation of the shoulder. So these are 3 types of dislocations of the shoulder. These are 3 types of dislocations of the shoulder, right? Now one by one we'll just discuss important points of each one of them, and then we see what are the common things in between them. Okay, so anterior dislocation, the first one, if we talk of the attitude, for the anterior dislocation, the attitude of the shoulder, it's abduction and external rotation, right? It's abduction and external rotation. Okay, abduction means the movement of the shoulder when it is moving away, the shoulder is moving away, it is abduction. Going back to neutral is neutral, or crossing the body is adducted state. So normally it is shoulder is in adducted state. So abduction. External rotation means like this. We can use this as a pointer, the forearm is a pointer, and when the forearm is going laterally, this is what you call external rotation of the shoulder, right? Not the forearm. So internally like this, internal rotation of the shoulder like this. So attitude of the shoulder for anterior dislocation, it is abduction and external rotation. Questions can be 2, answer remains 1. There are 2 questions which can be answered by this one line, abduction and external rotation. What is the force needed to produce the anterior dislocation of the shoulder? It is abduction plus external rotation. Or what is the attitude of the shoulder in anterior dislocation of the shoulder? It's same, abduction plus external rotation. Point number 2. Point number 2, right? This what are the different types of anterior dislocation of the shoulder? Anterior dislocation of the shoulder is commonly, I'm telling you, the common types are of 3 types. 1, it can be preglenoid. It can be preglenoid. Second, it can be subcoracoid, preglenoid or subcoracoid, or third, infra or subclavicular. Preglenoid, subcoracoid or infraclavicular. Out of these, the commonest one is subcoracoid, right? So anterior dislocation is the most commonest one of the 3, and subcoracoid is the most commonest type of anterior dislocation of the shoulder. Number 3, the clinical tests which are done for anterior dislocation of the shoulder, they are number 1 is Duga's test. What is the Duga's test? In Duga's test, we ask the patient to keep the hand on the opposite shoulder. When there is an anterior dislocation of this shoulder, what will happen is the humeral head, basically, if this, presume this to be my glenoid, right glenoid and head of humerus, what will happen is head of humerus is going in front anteriorly. That means the head is stuck like that. Ask the patient to touch the opposite shoulder, he won't be able to do so. That is Duga's test, number 1. Okay. Second one is a Hamilton ruler test. Second one is a Hamilton ruler test. Hamilton ruler test means, if you presume this to be a scale, if I put it on my right shoulder, it goes like this in particular direction, right? If I put it here at the elbow, it goes like this. But both these points, the elbow and the shoulder, cannot be touched at a time. right? In anterior dislocation, what will happen is the patient will have a shoulder where there is a prominence of the acromion, and when a scale is placed over here, the acromion and the lateral condyle, they both can be touched at the same time, right? So Hamilton ruler test. Third is Cavay's test, C-A-L-L-W-A-Y, Cavay's test. In Cavay's test, the circumference of the axilla is measured, right? It will be more in the dislocated side as compared to the non-dislocated or normal side, right? So the circumference of the axilla is increased in Cavay's test. Fourth is the treatment part. I said already that consider every dislocation to be an emergency. Consider every dislocation to be emergency, so reduce it as early as possible. So treatment is simple, it is reduction. What are the methods of reduction of anterior dislocation of the shoulder? The methods of reduction are Cocker's method. It is Cocker's method 1. Second, it is the Hippocratic method or the Stimson's gravity method. Hippocratic method or Stimson gravity method. Stimson's gravity method. These are three ways to reduce a anterior dislocation of the shoulder. The steps followed in Cocker's method are TEAM, T-E-A-M. How it is done? The Cocker's method, patient will come to you with the attitude like this, right? Hand held just by the side of the body, abducted straight, externally rotated. You will be able to see his elbow like this, okay? So what we do is, TEAM means, what does TEAM stands for? T stands for traction, give the traction in the same line, traction. Then externally rotate the shoulder, adduct the shoulder and medially rotate it. That is TEAM. Traction, external rotation, adduction and medial rotation, the TEAM, okay? So steps for Cocker's method, it is TEAM. Cocker's is the most commonly done or used method to reduce the anterior dislocation of the shoulder, that is TEAM. Traction, external rotation, adduction and medial rotation, okay? These are the 4 steps, right? Now coming on to the second one, the posterior dislocation of the shoulder. In posterior dislocation of the shoulder, the important points are number 1, the attitude in posterior dislocation of the shoulder, it is adduction, just reverse of the anterior one, it is adduction plus internal rotation, point number 1. Point number 2, in posterior dislocation, it is more common in 2 categories of patients. Posterior dislocation is common in 2 categories of patients. In patients who get a fall after electric shock, the patients who have a fall after electric shock, or the patients with the epilepsy episode, the seizure episode, right? So it is more common in epilepsy patients and it is more common in people who had a history of fall after getting an electric jerk. Number 3, another very important point about posterior dislocation is that the contour of the shoulder may be normal. The contour of shoulder may be normal. So contour of the shoulder may be normal. Number 4, there is no specific test for posterior dislocation. Only one non-specific test has been labeled and that's jerk test. Point number 5, X-rays, they show you 2 important features in posterior dislocation of the shoulder. One is known as electric bulb sign. And second is empty glenoid sign. How they look like, I'll just show you. Empty glenoid sign. Just note it down and I'll show you how they look like, right? What is that electric bulb sign? Normally, when you see the X-ray of the shoulder, it should be like this. Glenoid, anterior surface, head of humerus, anterior surface, this one. When there is a posterior dislocation, the head has to rotate internally like this. So instead of the anterior surface, now what you see is the lateral surface like this. This appears or this resembles the upper end of an electric bulb. That's why it has been given a name entity as an electric bulb sign or the lighthouse sign. Empty glenoid is when there is no articulation between these two and the head has gone to absolutely posteriorly. So this is now empty, nothing is articulating with it. That's why you call it an empty glenoid sign. This kind of dislocation is common in 2 people, those who fall after electric jerk or the electric shock basically, or when they have an episode of epilepsy. When somebody has got an electric shock, the first mechanism is to just keep the hand close to the body and when the patient falls, if there is impact over here, the head rotates like this internally, posterior side. So these two categories of patients, most commonly they have the posterior dislocation of the shoulder. If you see last, the MCQs from this particular topic, shoulder dislocation, and if the examiner wants to ask you posterior dislocation, he simply tells you that there was a worker who was working on an electric pole. Suddenly the electricity was switched on and he got an electric jerk and he fell down on the ground. After falling, the contour of the shoulder seems all right, right? Contour of the shoulder seems all right, but he is unable to use the shoulder for any kind of movement. What kind of problem he might be having? Can you guess that? See, contour of the shoulder, we have written point number 3, it may be normal. The reason is simple. Right now when I am sitting in front of you, I am holding my both hands, right? Now what exactly is at my shoulder? Is it normal? When I am holding my hand, is the shoulder normal? No, it has already got internal rotation, because normal position of the shoulder is when I am having both the hands like this by the side of my body, anatomically the palm facing in front. Get my point? When I am holding my hand, see what I have already achieved. Hand should have been like this, and when I try to do so, what I have achieved is, when I keep it like this, I have already made an internal rotation. That is what is required in posterior dislocation, right? So this posterior dislocation will always, or you can say in majority of the cases, usually the contour of the shoulder remains normal, which is not the entity here, which is not the entity in anterior dislocation, because the test we are doing is Hamilton ruler test. That simply tells you that the contour never remains normal in the anterior dislocation, it always disrupted. It is always disrupted. Okay, so 5 points about the posterior dislocation. Coming on to the inferior dislocation, point 1, the mechanism to produce inferior dislocation, it's hyperabduction. The mechanism to produce inferior dislocation, it is hyperabduction. How? Somebody is falling, falling from height, and he tries to hold on to one of the branch of a tree. Okay, so he simply says, "मैं just गिर रहा था और मैं तो बस लटक गया." No, like that. So he was just falling and he just placed a hand like this. What will happen? The head of humerus, which was supposed to be articulating here with the glenoid, what will happen? Abduction, 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 and more of abduction, and head slips down here, right? So hyperabduction is the force to produce the inferior dislocation of the shoulder. Okay. Number 2, this posture, the patient when he comes to you, the hand held over the head like this. This has been described as salute posture. This has been described as salute position or the salute posture. Number 3, there is something special in inferior dislocation which is known as sulcus sign. What's that sulcus sign? Sulcus sign is, if I trace my thumb from nape of my neck towards my shoulder, I can feel a normal contour. But when the head which was supposed to be here, it is dislocated and now lying here, it has gone down. What is going to happen? When I trace my thumb from here, when I go over here, reach over here at this point, what is going to happen? What I'm trying to or feel is, all this area will be empty, right? Why? Because the head which was supposed to be here has gone here. That all area, this area is empty now. That's what you call sulcus sign, right? So these are 3, 4 and 5 important points about different kind of dislocation. Okay, so if you want to mark the questions, I've told you the language also, how the questions are asked to you. So patient after electric shock, epilepsy, contour of the shoulder is normal. That's one very important point. Now how they look like on X-ray, have a look. Just have a look. See, on the first image, what do you observe? In the first image, you observe that you are able to appreciate the glenoid, even the complete glenoid actually, and then there is a head of humerus which is over here. The head of humerus which is over here like this. This is what you call electric bulb sign, right? The head of humerus has just rotated internally to give you complete appearance of like that of a electric bulb, upper end of electric bulb. This one is an anterior dislocation, right? So second picture, anterior dislocation, the first one is what you call an electric bulb sign. Now these are other 2 methods to reduce, as I told you, we discussed. This is what you call the Stimpson's gravity method, in which the patient actually lies prone and there is a weight which is tied to the wrist of the patient. This is Hippocratic maneuver, in which the examiner tries to put his foot into the axilla and he tries to pull the limb of the patient. This is not at all advisable, because instead of giving him relief, you may damage his glenoid, we may damage his head of humerus, we may damage the neurovascular structures. So it's not actually advisable, right? So if you are experienced enough, Cockers is more than enough to reduce any kind of shoulder dislocation anteriorly, obviously. So Cockers is more than good, right, in any of the given situations. Okay, now these are some different points about each of the dislocation, 4, 3, 4 and 5. Okay, what are the common points now about the dislocation? The common points, I'm telling you the common points now. What are the common points? The common points. The common points are the common points are: one is about the complications, There are two questions now here. What is the most common complication? Most common complication for all the three dislocation is same, and the most common complication remains recurrence, right? Most common complication remains recurrence. Okay. Second is, when they ask you about the most common acute complication, when they ask you about the most common acute complication, the most common acute complication remains the axillary nerve injury. It remains axillary nerve injury. Axillary nerve injury, basically, say, nerve injury will be a separate section, but we can keep on discussing the different nerves and their implications with the respective fractures also, okay? So axillary nerve injury, if it is gone, if it has happened, it will lead to two kind of, symptoms. One will be motor involvement, and this axillary involves one, deltoid, and second, teres minor. These two are involved in axillary nerve injury. When we talk of the sensory part, it will lead to something known as regimental badge sign. It will lead to something known as regimental badge sign. What is that regimental badge sign? Regimental badge sign means the area here on the lateral aspect of my shoulder, this area is being supplied by axillary nerve, right? When the axillary is paralyzed, this area where the people, the police people or the CRPF people, they wear a badge, this area will show me sensory loss, right? So sensory is regimental badge sign will be seen in the axillary nerve injury, or the motor part will be deltoid and the teres minor, right? This is about the complication. The most common complication is recurrence. Most common acute complication would be axillary nerve injury. Now, second part is, whenever there is a recurrence of dislocation, what they are going to lead to. Whenever there is a recurrence, what they are going to lead to, right? Recurrence of the dislocations, it can be an anterior dislocation recurrence or it can be a posterior dislocation recurrence. When the recurrence involves anterior dislocation, when it is a part of anterior dislocation, then what can happen is, anterior dislocation will produce or will show you two different kind of lesions. What they are? One, it will show you something known as Hill-Sachs lesion. Hill-Sachs lesion, right? Hill-Sachs lesion. Okay, so this is anterior dislocation of the shoulder, the Hill-Sachs lesion. Hill-Sachs lesion is seen on posterolateral aspect of humeral head. It is seen on posterolateral aspect of humeral head. It is seen on posterolateral aspect of humeral head. Okay. Second one is Bankart lesion. Second one is Bankart lesion. Bankart lesion is seen on anterior margin. It is seen on anterior margin of glenoid. It is seen on anterior margin of glenoid. Right? When there is a recurrence in anterior dislocation, we can see two different types of lesions. One is Hill-Sachs and other is Bankart. When there is a posterior dislocation, which goes with the recurrence again and again and again, here in this case we can see reverse Hill-Sachs lesion. Here we can see reverse Hill-Sachs lesion. That is reverse Hill-Sachs lesion. Obviously, when the Hill-Sachs lesion is on the posterolateral aspect of the humeral head, the reverse Hill-Sachs lesion is seen on anteromedial aspect of the humeral head. Right? It will be seen on the anteromedial aspect of the humeral head. So recurrence will be related to these kind of lesions. Right? Posterior dislocation has been described as McLaughlin's lesion. It is McLaughlin's lesion. It has been described as McLaughlin's lesion, right? So that is in short about the dislocations, and you should be very well versed about each of the given or highlighted important points about each of the dislocation, right? So clinically the question can be asked to you in many ways. A patient had RTA, post RTA you have evaluated him clinically, X-ray suggestive of no bony injury, contour is all right, but he is unable to use his shoulder. What can be the most likely diagnosis, right? That can be very well a case of posterior dislocation, when because there is no change in the contour. But if you see the upper differences of these three, you know that in the anterior dislocation as well as the inferior dislocation, there will be deformity around the humeral, this shoulder girdle area, right? So contour will be lost in anterior and inferior for sure, but in posterior it may remain normal in majority of the cases, right? So this is about the posterior dislocation, anterior dislocation and inferior dislocation of the shoulder.